Welcome to this edition of Perspective Inflammation podcast, a series brought to you by the CSF, Signaling Forum, which is China's authority hunter expert in the field of inflammation. And my name, introducing that, is Professor Maurizio Cutolo, coming from the University of Genova, Italy. And with me is my fellow at the CSF Steering Committee, member of the Professor Kevin Winthrop from Oregon Health and Science University. Welcome.
Hi, Maurizio.
Welcome, Kevin. So, a little interview that we will be discussing the concept of herpes zoster and how it relates to inflammation shortly. But first, it will be like to find out a little more about Professor Winthrop. For example, my question, what attracted you in the field of rheumatology, please?
Sure. Well, we'll try to keep it clean. I'm actually not a rheumatologist, you know that, and I'm an infectious disease person, or an infectologist, as you guys say in Europe. I've been a professor of infectious diseases and public health for about 15 years at Oregon Health Sciences in Portland, Oregon. But before that, I was actually based here in Atlanta with the Center for Disease Control. So the US CDC is the Center for Disease Control. It's our large federal public health agency. And at the time, I was quite young, and I was a TB expert, tuberculosis expert. And at the time, the TNF blockers were just coming out, and they were starting to cause TB. And I just happened to investigate an outbreak of TB in infusion centers on the west coast of the US. And so I was very interested in this problem. And just by luck, maybe one of the first people at CDC recognizing it. And actually, Professor Smolin called CDC and said, hey, you know, we're interested in this topic in Europe. Can you send someone over to help? So I was very lucky to be sent to Europe to meet you and Professor Smolin and others. And years ago to start working on the tuberculosis issue. And I think all of us worked really hard about designing guidance in terms of preventing TB and screening for TB. And a lot of us did a lot of research on improving that. And since that time, of course, there's been many new drugs. Your pipeline has been vast, often with different mechanisms of action, with the potential for causing not just TB, but all sorts of infections. So I became very interested with TB, and my interest broadened over time as your pipeline broadened. And we're going to talk about zoster today. I guess I'm pretty excited about cell-mediated immune infections in general, but granulomatous diseases and as well as viral diseases. So that's really been an evolving target for me over the years as the pipeline of therapeutics has evolved.
Thank you very much, very interested. But can tell you something more about your center where you work in Oregon, please?
Yeah, so I'm in Oregon. We have one major medical university in Oregon. It's quite a good university. I mean, I think it's in the top 20 or 25 in the country in terms of research. And we have a rheumatology division that's quite strong, and there's some really well-known people there. And I'm in the infectious disease division, and we have a school of public health. My research program is really based twofold. I mean, I have an infectious disease clinic where really it's a chronic chest infection clinic. I see lots of people with mycobacterial diseases. But the other half of that practice is really focused on immunosuppressed individuals, particularly patients with rheumatic disease or dermatologic diseases, IBD, et cetera, autoimmune inflammatory disease who are having infectious issues associated with their disease or their therapies. So alongside of that, our research program is really twofold, and it's very collaborative. I work very closely with Jeff Curtis at UAB and Len Calabrese, a number of people I've collaborated with, and that's been very fruitful. And I'm an epidemiologist, so a lot of what we do is look in large claims databases like Medicare, for example, and other databases, looking at the real world risks of not just infections, also other safety events with various therapies. And so that's, we've focused on rheumatology, particularly RA, but the last few years, of course, there's a lot of action in psoriatic diseases and other inflammatory diseases. So we've been really interested in that. So I'm an epidemiologist. We do those large cohort studies, and then clinically, we do a lot of trials, particularly around vaccines. So how do you prevent? So let's do a big study and figure out what the problems are with the drug, and then now let's figure out how to prevent them. So we really focus a lot on prevention, so people can benefit from the therapies. So that's largely vaccine trials, and we focus quite a bit on, the usual influenza, pneumococcal, and now shingles prevention. So those are the vaccines I think of probably primary interest to your field.
Yes, that is important because your key interests at present are vaccination and patient with autoimmune diseases.
Absolutely.
This is very, very important.
Well, and it's a huge unmet need, at least in the U.S., but also in Italy and elsewhere. I mean, our vaccine rates are not nearly what they should be. It's hard to convince people to get vaccinated sometimes. There's other barriers, cost and access to specialists who know what vaccine to give, things like that. But I mean, you guys are pretty smart. Rheumatologists are one of the smartest of the bunch. Other specialties are less up to date on these things. So, I work really hard in terms of trying to, do research and educate some of the other specialties and work hard with rheumatologists to try to bring up vaccine rates. It's we have, all the vaccine people, we struggle all over, with this. But I think the more data we have on efficacy and safety, the easier it is to convince people to vaccinate. So.
Oh, very nice, this overview, introducing your interest, your position. And now I would like to be a little more detailed in my questions regarding the different infection the patient affected by autoimmune disease, inflammatory disease may get. For example, could you elaborate on the risk of herpes zoster in inflammatory diseases? This is an important topic.
Yeah. Wow, this is a huge unmet need. I don't know when our interest started in this. Jeff Curtis and I started getting interested in this years ago around a table with other friends and experts, mainly because we had the clinical observations of a lot of patients with zoster, and particularly as the JAK inhibitors started going through development 5-7 years ago, this was obviously a problem. And it led us to look at baseline rates of zoster or shingles in all sorts of autoimmune diseases. And it was very clear that the risk was elevated across the board. 2 or 3-fold higher for RA, 4 times or 5 times higher for lupus, IBD, PSO, PSA, you name it. You name the inflammatory disease, the risk is higher. And of course, as you age, the risk is higher. And of course, some of your other therapies, not just JAK inhibitors, steroids, and maybe some biologics, also carry some risk. So it was very clear at the time that the risk was high, and then we did some work looking at databases. At least in the U.S., the use of the vaccine was, like this, 3% or 2%, 4%. I mean, very few people. Now that's changed. A lot more people have been vaccinated. Now we have another vaccine out that we're starting to use. So, a lot's changing. But I think at the time, that was 7-8 years ago. We really became interested because we noticed the incidence was high and the incidence is increasing. And I should say that aside from rheumatology and autoimmune patients, I mean, if you look at the curves of incidence in North America, in any age group, young, old, in the middle, they're all going like this. And we don't quite know why. We have lots of theories, but the incidence of shingles is increasing across the board. So there is a big unmet need there.
And you mean in general population?
In general population.
General population. But you mentioned that concomitant treatment, of course, enhance the risk.
Absolutely. So, I mean, not only is it increasing the general population, but then you add the increased risk associated with your diseases. I mean, RA is a classic disease where cell-mediated immunity is decreased due to the disease. So actually, when you treat RA and make it better, you probably decrease the risk a bit. But again, some of those therapies outweigh that and promote the risk even higher. So in many of those patients, like you said, they're on multiple risk enhancers, right? They're on steroids, they're on a JAK inhibitor, they're on or whatever. I mean, methotrexate, methotrexate probably doesn't carry a lot of risk. In fact, I'm not sure it does increase the risk very much.
You think so? Yeah.
But you can imagine the layering of risk on many of these individuals, and that's a challenge for patients and for doctors to control. So.
Yeah, this is interesting. Now going back to the concept of vaccination, So, but not the general vaccination, but the specific vaccination for herpes zoster. Do you think that reduce the risk of infection in patients with inflammatory diseases, autoimmune disease?
Yeah, well, we have two vaccines, and I'm not sure where the subunit vaccine is in Europe. I think it's approved. I'm not sure how available it is. In the U.S., it's approved. It's available, although the vaccine's been in short supply. It's been hard to get. We have the older vaccine, the live vaccine, which we've used for years, which we did a lot of research with up until now. Now we're, of course, switching our research focus to the new vaccine to collect some efficacy and safety data in your population specifically. But the new vaccine has promised to be more efficacious. Now, even the old vaccine, I mean, there was some efficacy. We saw that in a large trial, randomized controlled trial that we did in patients using TNF blockers, actually. That's being reported here at ACR this year. We've also done population-based work where, several years ago, where we also saw efficacy from the vaccine. So I think there is some efficacy with the live vaccine, but I think the new killed vaccine, of course, in the general population, the efficacy looks much more robust. We'd expect to see that also in the rheumatic disease population, but we don't know yet. It probably won't be as good as it is in healthy non-inflammatory disease patients, but I expect there to be some good possibilities of preventing disease with that vaccine.
So in your experience, if you have a patient with inflammatory or autoimmune disease that must start immune suppression, do you think this should be correct to start with a vaccination for, in this case, for herpes?
Yeah, it really depends on how old they are. And the vaccines, both the live and the subunit vaccine, they're both labeled for people over age 50. Now one can argue, and the question I always get is, well, what about the 30-year-old lupus patient whose risk is, way higher than the regular 50-year-old? Yeah. So the regular population. So these are good questions. We're going to do a study looking at the new vaccine in patients down to 18 years of age, actually, because I think there are some risk groups in the younger population that it's high enough where there's probably justification for its use. So
the age is one indication.
Age is huge. So in the U.S., at least, I mean, if you're over age 50, you're a candidate for zoster vaccine. If you have access to the new vaccine, the subunit vaccine, it's likely going to be more efficacious. There's not a lot of data yet in the rheumatic disease populations or inflammatory disease populations with that vaccine. There's kind of this theoretical risk that maybe it might promote disease flares. This is a risk. Every vaccine that ever comes out, there's always the risk that it could flare underlying disease. So it's important to study that question to see if that actually happens, and if it does, generally I think it's probably a manageable situation anyway. We have seen some limited use of the new vaccine. In fact, at ACR here, there's one report of several hundred people who've used it, and they seem to have used it quite successfully, although there's not any efficacy data or immunogenicity data yet. So we're hoping to do that study. I know other people are planning studies as well, but I do think it looks promising.
Just a question that is a lot of doctors, our listeners probably, they have. When you vaccine, and at the same time you use immune suppression, something like, do you think that reduce the action, the efficacy of the vaccine, or no? This is a question very difficult, I know.
So there's more and more data on that. We've presented data on that before. I was lucky to help Yoongbong Lee's group in Korea. They produced some great data last year that was published actually this year, looking at the influence of methotrexate and the influenza vaccine. I think we all probably suspect that methotrexate influences most of our vaccines. We know that with pneumococcal vaccine. Whether it influences shingles vaccine or not, we don't know, but I would like to study that. That's in my plans. But I think, probably, stopping sometimes immune suppression around the time of vaccination can be useful.
Okay, this is important.
That's important, yeah. And it really depends on what the drug is, right?
Of course.
What its half-life is, how it works. So it's probably different for different immunosuppressants.
Okay. So thank you very much again, Kevin, Professor Winthrop, to have this wonderful discussion, which was very productive and useful. I think so. Thank you very much.
Yeah, thanks very much for having me.
Yes, I hope that everyone enjoyed the contents and they gained some news about this important aspect, herpes zoster and inflammation. And I would like to remind to the listeners that to subscribe to Cytokine Signaling Forum must be one of your favorite podcast app, and visit frequently because there is a continuous new materials, including slides from new publication and summaries from Congress, and monthly is dedicated to the podcast, and it hosted again by CSS, and the chairman is Professor Ian McInnes. Thank you very much.